Today, we are tackling a truly fundamental topic in medical education: anatomy.
Right, anatomy. It's arguably the oldest science in medicine, and for literally millennia, it's been taught through this incredibly immersive experience, hands-on dissection of the human body.
It's the absolute cornerstone.
But, the digital revolution hasn't just stopped at textbooks. It's well and truly in the lab now, offering these hyper-realistic 3D models, virtual reality setups, even complex digital dissection platforms. So for you, the learner, whether you're starting out or trying to get up to speed in this field, there's a really immediate high-stakes question. Which way works better for actually keeping the knowledge long-term? Is it the traditional, tactile, maybe even visceral experience of dissection? Or is it the modern, clean, digital visualization?
And that's exactly what we're setting out to explore today. Our mission is to really unpack the data. We've got a detailed quasi-experimental study that put these two methods head-to-head.
Okay.
Then we'll zoom out a bit, look at why anatomy remains so incredibly vital for modern clinical practice, especially now with all the advanced imaging we rely on.
And finally, we have to delve into the history, the tradition, and frankly, the profound ethical context surrounding the study of the human body itself. It's a deep one.
It really is. And fair warning, the results from that knowledge retention study, they might just challenge some long-held assumptions about what traditional necessarily means for effectiveness.
All right, sounds fascinating. Let's dive in.
Okay, so first things first, let's ground ourselves in the evidence. Our sources give us this really rigorous study, sometimes called the Lucknow experiment internally.
Right.
It was conducted over a full academic semester at the Prasad Institute of Medical Sciences in Uttar Pradesh, India. And its whole purpose was to directly compare these two teaching approaches.
Now, you mentioned it's a quasi-experimental study. What does that mean in practice? Were the groups perfectly matched?
Good question. It means it wasn't a perfectly randomized controlled trial in a sterile lab setting, but the researchers were incredibly careful in how they designed it to control variables. They wanted a fair fight, essentially.
Okay, so how did they set up the groups?
Well, they started with 120 first-year MBBS students. That's the standard medical degree in India and many other places. Bachelor of Medicine, Bachelor of Surgery.
Got it. 120 students.
Yep. And they split them into two groups, 60 students each. Now, critically, they made sure these groups were comparable. They looked at demographics like age and gender, balanced those out. But they also tracked previous academic performance.
So one group wasn't just naturally stronger academically.
Exactly. They wanted to minimize that bias, ensuring that any differences they saw later were much more likely due to the teaching method itself, not just because one group started out ahead. That teaching methodology was the main variable they were testing.
Makes sense. So Group A, what did their learning look like? The traditional path.
That's right. Group A, all 60 of them, got the classic time-honored anatomy education. This meant hands-on cadaver dissection, the physical exploration of a donated human body.
The real deal.
The real deal. Supplemented, of course, by standard didactic lectures, the usual classroom format, and they use the big standard textbooks and anatomical atlases. It's that very tactile, weighty experience people associate with anatomy.
Okay. And Group B, the modern approach.
Group B, the other 60, went fully digital. They had access to these advanced digital anatomy platforms, sophisticated 3D modeling software, the kind where you can rotate structures, peel away layers virtually.
Pretty cool stuff.
Yeah, and interactive multimedia animations, detailed videos, plus specialized virtual dissection tools that simulate the process without needing a physical body.
And crucially, did both groups get the same information?
Absolutely critical point, and the researchers confirm this. The core anatomical content was identical for both groups. The quality of the information didn't change. Only the delivery system, the way they learned it, was different.
Right, that control is everything. If the info's the same, any score differences should point to the method. So let's talk results. What happened right after the teaching ended? Immediate outcomes.
The results were pretty clear right away. The modern digital approach, Group B, showed an immediate and statistically significant advantage.
Significant, okay.
How much better?
On the immediate post-teaching assessment, Group B's total mean score was 74.9, whereas Group A, the traditional group, scored 70.5.
So about a 4.5-point difference for you listening. How solid is that finding? Is that just random chance?
Very unlikely to be chance.
Yeah.
The researchers calculated the p-value, and it was less than 0.05.
Yeah.
In statistical terms, that means the result is considered significant. There's a very low probability it happened randomly.
So basically, the digital method led to better immediate understanding or mastery of material right out of the gate. And it wasn't just about simple memorization either.
Oh, how so? Did they test different kinds of knowledge?
They did. The assessment wasn't just one thing. It included multiple choice questions, MCQs, which often test quick recall, then short answer questions, SAQs, needing more description or explanation, and importantly, practical identification tasks, pointing out structures on images or models.
And the digital group did better on all of them.
Across the board, yes. Their superiority held up. For example, those identification tasks, which you could argue are a bit closer to practical application, the modern group scored an average of 73.5 compared to 68.9 for the traditional group. That really suggests the digital tools were better at building that reliable foundational understanding quickly.
Okay, immediate win for digital. But here's the million-dollar question for our learner. Retention. Does that intense, maybe unforgettable experience with a real cadaver actually burn the information into your brain better long-term compared to clicking through screens?
This is probably the most striking finding, and it definitely challenges that long-held belief about the cadaver's superiority for memory. They tested the students again 3 months later.
The delayed post-test.
Exactly. And Group B, the digital group, still had significantly higher knowledge levels. Their total mean score after 3 months was 68.7, while Group A, the traditional group, was down to 63.6. And again, this difference remains statistically significant.
Wow. So let's talk about the forgetting itself. I mean, everyone forgets some stuff after a course ends, right? Was the drop-off just less steep for the digital group?
That's precisely it. You hit the nail on the head. Both groups obviously saw a decline in their scores over those 3 months. That's natural. But the amount they forgot was less in the digital group.
How much less?
Group B scores went down by about 8.3% from their initial score. Group A scores dropped by 9.8%. Now, that difference might sound small, just over 1.5%, but statistically, it's meaningful. It strongly suggests that the digital tools don't just help you learn faster initially, but they also seem to promote better long-term consolidation. The knowledge sticks around better.
So wait a minute. If the hard data shows students learn better immediately, and they remember it better long-term, and as we'll get to, they seem to like it more, why is cadaver dissection still seen as so essential? Is it just tradition clinging on, or is there a cognitive reason why digital might be working so well for retention?
That's the core question, isn't it? The researchers proposed a few cognitive advantages for the digital approach. First off, spatial reasoning.
Okay.
Think about it. With a 3D model, you can spin it around, zoom in, fly through complex structures like nerve networks or blood vessels in a way that's just impossible with a static textbook illustration or even a single dissected specimen.
Yeah, you get all the angles.
Exactly. Seeing those relationships from multiple dynamic perspectives seems to really enhance spatial understanding, building a better mental map.
Okay, that makes sense. What else?
The second big one is accessibility and repeatability. In a traditional lab, you have limited time with cadaver. The specimen is finite. If you make a wrong cut or miss something, well, that's it. You can't just rewind.
High pressure.
Very high pressure.
Yeah.
But with digital platforms, you have infinite review. A student struggling with, say, the brachial plexus can revisit it 50 times from different angles at their own pace until it clicks. There's no penalty for messing up.
Lower stakes, more practice.
Precisely. It reduces the cognitive load, the stress that can actually interfere with learning, especially with something as complex as anatomy. And this kind of flexible, self-paced learning really clicks with how many students today, the digital natives, prefer to learn.
Yeah, I can see that. Reduced pressure, unlimited practice, better visualization tools. It seems logical it would lead to better scores. What about the students' actual experience? Did they feel better about the digital method?
Oh, overwhelmingly yes. The feedback was starkly different. Group B, the digital group, reported significantly higher overall satisfaction with the course. Their scores were 4.2 versus 3.8 on whatever scale they used.
Okay.
They also reported feeling much more engaged with the material, 4.4 versus 3.7. And, maybe most tellingly, they perceived the learning experience itself as significantly easier, 4.5 versus 3.6.
Easier, more engaging, more satisfying, and better scores. That's a powerful combination.
It really is. And the researchers noted that alignment, the positive subjective experience, seems to directly correlate with the better objective performance and retention. When you feel less stressed and more engaged, you learn better and remember more.
One more detail from the study, you mentioned it earlier, the correlation with previous academic performance. What was the finding there? Did it matter how well students had done before?
It did, to some extent. Interestingly, they found that factors like age or gender didn't really correlate significantly with how well students retained the information in either group. But there was a moderate positive correlation between a student's prior academic record, their baseline strength, you could say, and their final retention scores. And this effect was particularly noticeable in the modern digital group.
So stronger students benefited even more from the digital tool.
That seems to be the suggestion. Students who already had strong study habits or a good academic foundation seemed better able to leverage the accessibility and advanced features of the digital resources to really maximize their learning gains.
Okay, so let's synthesize this first deep dive. The hard data, at least from this Lucknow study, points quite strongly towards digital methods being more efficient, more satisfying for students, and actually resulting in better long-term recall of anatomical facts.
That's the quantitative story, yes.
But, and this is a big but, the researchers didn't just say, okay, ditch the cadavers, did they?
Absolutely not. And this is crucial. Despite the compelling data on retention and satisfaction, the study's conclusions strongly reaffirmed that traditional methods, especially the actual hands-on cadaveric dissection, offer something unique and irreplaceable.
What is that something?
It's the tactile reality, the immersive, multisensory experience of working with real human tissue, the appreciation of natural variation between bodies, the development of manual dexterity that might be relevant later, and, as we'll discuss more, the profound ethical and humanistic lessons.
So it's not an either-or situation.
Definitely not. The researchers didn't see it that way, and most educators don't. The suggested path forward isn't about choosing one over the other, but about finding a smart, balanced integration. Using digital tools for their strengths in visualization and repeatable learning, while preserving the unique, invaluable experience of the cadaver lab for its own distinct benefits.
Okay, so we've seen the data on how students might learn anatomy best. Now let's pivot to why this knowledge is so incredibly critical in the first place, especially in today's medical world.
Right. Because anatomy isn't just some basic science hurdle you jump over in first year and then forget. It is fundamentally the language of clinical medicine. It underpins everything else.
How so? Connect the dots for us.
Well, think about the other core sciences. Physiology, how the body functions, makes no sense without knowing the structures involved. Pathology, the study of disease, is largely about how disease alters structure.
Yeah.
And surgery. Well, surgery is literally applied anatomy. You can't intervene physically without knowing the map precisely.
It sounds obvious when you put it like that, but maybe give an example of how that anatomical knowledge plays out in a doctor's daily decision-making.
Okay, take diagnostic precision. A patient comes in with symptoms, let's say abdominal pain. Where is it exactly? What organs are located there? What nerves supply that area? What blood vessels? A clinician uses their anatomical knowledge constantly to build a differential diagnosis, a list of possible causes.
So it helps narrow things down.
Tremendously. Knowing the precise relationships between structures allows them to interpret symptoms accurately, to understand the results of a physical exam, and crucially, to interpret diagnostic imaging correctly. They also need to know about common anatomical variations. People aren't all built exactly like the textbook pictures. Understanding that helps predict risks and avoid errors.
Can you link that directly to better patient outcomes? Is there evidence for that?
Yes, absolutely. The medical literature consistently shows a strong positive correlation. Clinicians with a more robust, detailed anatomical understanding demonstrate higher diagnostic accuracy across many fields, from neurology to orthopedics to internal medicine. They're less likely to misinterpret findings or order unnecessary tests.
Give us another concrete example, maybe something neurological.
Sure. Imagine a patient presents with weakness and numbness in their hand. Without detailed anatomy, you might just think hand problem. But a clinician with strong anatomical knowledge will immediately start thinking, which nerve supplies that specific pattern of numbness? Is it the median nerve, suggesting carpal tunnel? Is it the ulnar nerve? Or could the problem be higher up, in the brachial plexus in the shoulder, or even the spinal cord in the neck? That precise anatomical mapping is essential for localizing the lesion and ordering the right tests, like nerve conduction studies or an MRI of the correct area.
That level of precision must be even more critical in the operating room.
Oh, absolutely life-saving. Surgical safety is applied anatomy. Surgeons are working in incredibly complex three-dimensional spaces, often dealing with tissues distorted by disease or previous surgeries. They need a precise mental map.
To avoid complications.
But exactly. Minimizing complications, reducing damage to healthy surrounding tissues, preserving critical nerves and blood vessels, it all hinges on knowing precisely where you are and what's next door. Think about complex procedures like removing a brain tumor, performing an organ transplant, or even doing minimally invasive robotic surgery. The surgeon needs to anticipate where vital structures are, even when they can't directly see them.
A mistake could be catastrophic.
Devastating and permanent. Confusing an artery for a vein, accidentally nicking a major nerve during cancer surgery. These aren't just technical errors. They're failures of applied anatomical knowledge with profound consequences for the patient's function and quality of life.
This need for seeing inside in detail brings us perfectly to sectional anatomy. You mentioned this earlier. How is sectional anatomy different from the gross anatomy you learn from dissecting a whole body?
It's a different way of seeing. Gross anatomy, the kind you learn primarily through dissection, is about the overall form, the surface features, the continuity of structures in 3D space. Sectional anatomy is about understanding the body as if it's been sliced into planes, typically axial, like horizontal slices, sagittal, dividing left and right, or coronal, dividing front and back.
Like looking at slices of bread.
Kind of, yeah. It's about recognizing structures and their relationships within those specific 2D slices. And this became absolutely essential because our most powerful modern imaging tools, CT and MRI, present the body to us precisely in this sliced format.
So technology forced this shift in thinking. When did that happen?
The big shift really kicked off in the 1970s with the widespread adoption of computed tomography CT scans. And then it solidified even further in the 1980s with magnetic resonance imaging MRI.
Before that, doctors mostly relied on X-rays, right? Which are more like shadow pictures.
Exactly. Standard X-rays are projectional. They collapse 3D structures onto a 2D film. CT and MRI, however, provided these incredible cross-sectional views deep inside the body, revealing details in living patients that were previously only visible during surgery or autopsy. But interpreting these images required clinicians to develop a whole new skill, thinking anatomically in slices.
Let's quickly break down those key modalities for anyone listening. What's the fundamental difference between CT and MRI, and what's each good for anatomically?
Okay, CT scans use X-rays, essentially taking multiple X-ray projections from different angles and using a computer to reconstruct cross-sectional images. Their strength lies in showing differences in tissue density.
So, good for bone?
Excellent for bone, which appears very bright white. Also great for trauma, looking for internal bleeding, blood density differs from tissue, or detecting things like kidney stones. It's fast and widely available. And while the primary images are axial slices, modern CT scanners allow for multiplanar reconstruction, or MPR. MPR lets the computer take the stack of axial slices and reformat the data to create images in other planes, sagittal, coronal, even oblique or curved planes, or generate 3D renderings. This is hugely valuable for surgical planning, letting surgeons see the anatomy from multiple perspectives before they even make an incision.
Okay, so CT is the density and bone expert. What about MRI?
MRI is completely different technology, no X-rays. It uses powerful magnetic fields and radio waves to manipulate the water protons in your body tissues. Different tissues like muscle, fat, brain matter, fluid respond differently to these magnetic fields, giving off distinct signals.
And that translates to?
Incredible soft tissue contrast. MRI is the king for looking at the brain, the spinal cord, joints, ligaments, tendons, cartilage, muscles. Basically anywhere the subtle differences in soft tissue are important. It provides amazing anatomical detail without any ionizing radiation, which is a big advantage, especially for children or patients needing repeated scans.
But it's slower and maybe less available than CT.
Generally, yes. MRI scans take longer, are noisier, and can be more challenging for claustrophobic patients or those with certain metal implants.
And now we're even combining these technologies.
We are. Hybrid imaging is the cutting edge. Things like PUTI-CT or PMRI.
PUTI.
Positron emission tomography. PE is a functional imaging technique. You inject a tiny amount of a radioactive tracer, often linked to glucose, and the PET scanner detects where that tracer accumulates in the body. Areas with high metabolic activity, like active cancer cells, light up brightly on a PET scan.
So it shows function, not just structure.
Exactly. But PET images alone are often anatomically fuzzy. By fusing the PD data with a detailed anatomical map from a simultaneously acquired CT or MRI scan, you get the best of both worlds.
So you can see exactly where that metabolic hotspot is located structurally.
Precisely. PTT, for example, is invaluable in oncology for staging cancer, finding out exactly where the tumor is, if it is spread to lymph nodes or other organs. This requires pinpoint anatomical localization provided by the CT component. It demands the clinicians understand both the metabolic information and the sectional anatomy perfectly.
Looking ahead, how is technology going to keep pushing the importance of sectional anatomy? Is it AI, 3D modeling?
All of the above. We're seeing huge advances in taking those 2D sectional image slices, from CT or MRI, and using software to automatically generate patient-specific 3D models. Surgeons can then use these models for preoperative planning, practice complex procedures virtually, or even use them for navigation during surgery.
Wow.
And yes, artificial intelligence is playing an increasingly large role. AI algorithms are being developed to help radiologists interpret images more quickly and accurately, flagging potential abnormalities. AI is also getting very good at image segmentation, automatically outlining specific organs, tumors, or blood vessels on sectional scans.
Does AI make the anatomist obsolete?
Not at all. If anything, it reinforces the need for deep anatomical understanding. The AI tools are powerful aids, but the clinician still needs the foundational knowledge to verify the AI's findings, understand the clinical context, and make the final decisions. The need to think in slices, to understand those spatial relationships revealed by imaging, is only becoming more critical.
Okay, so we've established the modern clinical necessity, driven by imaging. But to really grasp the significance of anatomy, especially the role of the cadaver, we need to step back into history. This field has an incredibly long and, frankly, sometimes unsettling past.
It really does. If modern anatomy is increasingly defined by the digital slice, its deep tradition is defined by the physical cut. Understanding that journey helps us appreciate the weight, both literal and ethical, of using the human body for teaching.
Where do we even begin? How far back does this go?
Well, recognizable anatomical observations go way back. We see hints in ancient Egypt. The Edwin Smith Papyrus around 1600 BC mentions organs like the heart, liver, spleen, blood vessels. It shows some awareness.
But systematic study started with the Greeks.
Yes, the philosophical and early scientific groundwork was laid by the ancient Greeks, figures like Alcmaeon and Empedocles in the 5th and 4th centuries BCE. But the really dramatic leap, the beginning of human dissection as a practice, happened later.
Where was that?
In Alexandria, Egypt, during the Hellenistic period, around the 3rd century BCE, this is where two figures, Herophilus and Erasistratus, made anatomical history.
How? What did they do that was so different?
They were the first physicians we know of who systematically dissected human bodies to study their structure. This was a radical departure from relying solely on animal comparisons or just external observation.
And they made some major discoveries doing this.
Huge discoveries. Herophilus, for instance, meticulously described the nervous system, distinguishing motor nerves from sensory nerves and differentiating nerves from tendons. He described the valves of the heart, traced the connections of the brain.
And didn't he also shift our understanding of intelligence?
Critically, yes. Before him, thinkers like Aristotle placed the seat of intelligence firmly in the heart. Herophilus, through direct observation of the brain and nerves, argued convincingly that the brain was the center of intellect and nervous control. A monumental shift.
But there's a darker side to Herophilus's work too, isn't there? The sources mention vivisection.
Yes, that's the deeply troubling part. Historical accounts, primarily from the Roman writer Celsus centuries later, allege that Herophilus, and possibly Erasistratus, performed vivisections dissecting living individuals, specifically condemned criminals provided by the rulers.
That's hard to even comprehend ethically today.
It is. While we have to be cautious about accounts written long after the fact, the possibility casts a long shadow. It highlights how the quest for anatomical knowledge hasn't always been constrained by the ethical boundaries we now consider fundamental.
After this sort of brief, intense period of human dissection in Alexandria, things changed again, right? We entered the long era dominated by Galen.
Indeed. Galen of Pergamon, who lived in the 2nd century CE, was an absolute giant of medicine, a brilliant physician and philosopher whose writings became the undisputed medical authority in the West for an astonishing 1,300 years.
But he wasn't primarily dissecting humans, was he?
No. By his time, Roman law and cultural attitudes had shifted again, and human dissection was largely prohibited. So Galen, despite his brilliance and extensive writings on anatomy, based almost all his anatomical knowledge on dissecting animals.
Which animals mainly?
Primarily Barbary apes, because they looked somewhat human externally, and also pigs and oxen. He was a master comparative anatomist, but the problem was he extrapolated his findings from animals directly to humans.
And because he was Galen the authority, nobody questioned it for centuries.
Pretty much. His system was so comprehensive, so logically structured, that it became dogma. Medical education involved learning Galen, not necessarily looking at the human body itself. This led centuries of ingrained errors based on these animal comparisons.
Can you give us a classic example of a Galenic error that persisted because he studied apes or oxen?
Sure. One famous one is the retin-mirabile, the wonderful net. This is a complex network of arteries and veins found at the base of the brain in hoofed animals like oxen. It helps cool the blood going to the brain. Galen found it in oxen, assumed it must be in humans too, and described it authoritatively.
But humans don't have it.
Humans absolutely do not have a retmeribial. Yet, for over 1,000 years, medical texts described it as a human structure based purely on Galen's authority derived from animal dissection. Another big one was his model of blood circulation. He believed blood was produced in the liver, flowed out to the tissues through the veins, like an irrigation system, not a circuit, and that the heart didn't really pump but sort of sucked blood in. Errors that lasted until Harvey in the 17th century.
It's mind-boggling. 13 centuries of relying on fundamentally flawed anatomy. It took the Renaissance to break that mold. And the key figure here is Andreas Vesalius.
Vesalius. Born in 1514, he is, without exaggeration, the founder of modern observational evidence-based human anatomy. He was trained in the traditional Galenic system, but became deeply frustrated by it.
What frustrated him specifically?
He hated the standard medieval teaching method. You'd have the professor, the lector, sitting up high on a chair, literally reading aloud from Galen's ancient texts.
Well, someone else did the messy work down below.
Exactly. A lower status assistant, often a barber surgeon called dissector, would be doing the actual cutting on the cadaver. And sometimes a third person, the ostensor, would point vaguely with a stick to the parts being read about. There was this huge disconnect. The professor often barely looked at the body.
So Vesalius decided to get his hands dirty.
He did. He fundamentally rejected this hierarchy and the reliance on ancient text over direct observation. He insisted on doing the dissections himself, right there in front of the students. He embodied all three roles: reading, when necessary, pointing, and cutting. His core principle was revolutionary for the time. See for yourself. If the human body in front of you contradicts Galen, then Galen is wrong. Evidence trumps authority.
And this culminated in his masterpiece, the book De Humani Corporis Fabrica in 1543, on the fabric of the human body.
A landmark publication, not just in medicine, but in printing history. The Fabrica wasn't just text. It was filled with incredibly detailed, anatomically accurate woodcut illustrations, based directly on Vesalius's own human dissections.
Why were the illustrations so important?
Because they showed the difference. They visually demonstrated undeniably that Galen had often been describing the anatomy of apes or dogs, not humans. For instance, Vesalius showed the human jawbone, mandible, is one single bone, not two as Galen claimed based on animals. He showed the human breastbone, sternum, as 3 parts, not 7 like in apes. The Fabrica's combination of meticulous observation and stunning visual representation set a completely new standard for anatomical study.
It basically said, look at this. This is what humans actually look like inside.
Precisely. It was a declaration of independence from ancient authority and the dawn of modern empirical anatomy.
Which brings us back full circle to the cadaver today. Even with amazing digital tools proven to boost retention, why is that physical encounter with the donor body still considered so vital? You mentioned humanistic values earlier.
Yes. Beyond just learning structures, the cadaver lab is seen as absolutely instrumental in cultivating core professional attitudes and values. For many students, it's their first direct encounter with death and the human form in this context.
And that fosters.
It helps develop what's sometimes called detached concern, the ability to maintain scientific objectivity and emotional resilience needed to perform medical procedures, while simultaneously retaining respect, empathy, and a profound sense of responsibility towards the person whose body has been entrusted to their learning. It's a unique space for grappling with mortality and the privilege of studying the human form.
That sounds incredibly important, but also logistically and ethically complex to manage. How do institutions handle body donation today? What are the rules?
The bedrock principle globally is informed consent. It has to be explicit, voluntary, and written, obtained from the individual before their death. This isn't just a checkbox.
What needs to be in that consent?
The consent form has to be detailed. It must clearly state how the body will be used for teaching medical students, for surgical training, for specific research projects, potentially for long-term preservation methods like plastination. It also needs to cover the final disposition of the remains, which is typically cremation, and clarify who covers the costs. Usually the institution covers transport and cremation. The process must be free from coercion and fundamentally altruistic.
You mentioned altruism. Let's talk money. Can people be paid for donating their bodies?
Generally, no. There's a very strong legal and ethical prohibition in most places, like Spain and Switzerland, which were highlighted in our sources, against any financial payment for the act of donation itself. It has to be a gift.
Does money creep in elsewhere?
That's where the ethical debates get heated. While the initial donation is altruistic, sometimes commercial companies get involved. They might receive donated bodies and then charge significant fees for surgeons or others to use those bodies for training workshops. Or, even more controversially, there's the issue of commercial companies involved in the plastination and public exhibition of bodies.
Right. The anatomical exhibitions, like body worlds, that's generated a lot of discussion. What's the general ethical consensus there?
The established anatomical societies are quite clear on this. While plastination itself is a valid preservation technique useful for teaching, putting these bodies on public display for an entrance fee raises serious ethical questions. The consensus is that such exhibitions must primarily serve genuine scientific education and public health communication, not just morbid curiosity or entertainment.
And consent is key here, too.
Absolutely critical. If a body is going to be preserved long-term via plastination and then put on public display, especially if it's posed in non-anatomical dynamic ways, the donor needs to have given specific, explicit consent for that exact purpose, public display, and the manner of display. General consent for teaching and research is widely considered insufficient for commercial exhibition.
Okay, so the ethics are paramount. But there are also practical challenges, right? Our sources mention potential issues with just managing the supply of donated bodies.
Yes, it seems counterintuitive, but anatomy departments can face logistical hurdles even with generous donors. The example from Lausanne, Switzerland was quite revealing. They'd run successful public awareness campaigns and had a large increase in the number of people registered to donate, over 1,900 in their region.
Sounds like a good problem to have.
It is, but it creates challenges. Firstly, the average age of incoming donors was quite high, around 85. Secondly, death is unpredictable. You might have periods where many donations arrive close together, exceeding the department's capacity for refrigerated storage or the specialized tanks used for chemical preservation.
So they might have registered donors, people who made this commitment, but literally no room to accept the donation when the time comes.
Exactly.
Yeah.
And that creates an ethical obligation to still honor the donor's wish to contribute to science. This is why interinstitutional cooperation becomes essential.
They share bodies between universities.
Yes. Networks exist, for instance, in Switzerland and Spain, where anatomy departments coordinate. If one institution is at capacity, they can arrange for the body to be respectfully transferred to another university's anatomy department that has space and need. This ensures the donor's gift is utilized for medical education or research as intended.
Who handles the paperwork and final steps then?
Typically, the original receiving institution, the one the donor registered with, maintains the primary responsibility for the administrative follow-up with the family and ensures the eventual dignified disposition of the remains, usually cremation and return of ashes if requested, even if the body was used elsewhere. It keeps the process respectful and accountable.
Okay, we have covered a massive amount of ground here. We've gone from the hard numbers of the Lucknow retention study through the critical role of sectional anatomy in modern imaging, all the way back to Vesalius challenging Galen and the complex ethics of body donation today. How do we synthesize all of this for you, the learner?
I think the synthesis is that the modern world of medicine absolutely demands mastery of cutting-edge digital visualization, sectional anatomy, 3D modeling, even AI interpretation. The data suggests these tools are highly effective, maybe even superior, for efficient learning and building that durable, factual knowledge base about structure. You could call this the intellectual core of precision medicine. But history, tradition, and frankly, the lived experience of generations of physicians tell us that nothing fully replaces the unique encounter with the cadaver. That tactile, sensory, sometimes emotionally challenging experience seems crucial for building not just 3D spatial understanding in a different way, but also clinical competence, appreciating human variation, developing manual skills, and, perhaps most importantly, forging the empathy and ethical grounding required of a clinician. That's the humanistic core.
So the takeaway isn't digital or dissection, it's digital and dissection.
Precisely. The most effective learning environment likely combines the best of both worlds, leveraging the accessibility, repeatability, and visualization power of digital tools while retaining the irreplaceable, profound learning experience that only the traditional cadaveric dissection can offer. It's about finding the right balance for the specific learning objectives.
Which leaves us with one final provocative thought for you to mull over as you integrate all this. We've seen compelling evidence that digital platforms and 3D modeling seem scientifically better for immediate learning and long-term retention of anatomical facts. So Could it be that the future of anatomy education isn't really about choosing one method over the other for teaching the basics? Perhaps the role of cadaveric dissection might evolve, maybe becoming less of a primary teaching tool for rote learning and more of a sacred high-fidelity assessment. Almost like a capstone experience, the ultimate irreplaceable test of a student's integrated anatomical knowledge, their practical skills, and perhaps even their professional character and readiness to care for the human body.
That's a really interesting thought to end on, shifting its role from primary pedagogy to ultimate validation. Definitely something to consider.